Uh, I want to welcome each of you here today to the Fred Hutchinson Cancer Research Center. This is actually our 5th annual Prostate Cancer Symposium sponsored by the Institute for Prostate Cancer Research. It's great to see some familiar faces, old faces as well as new ones attending the symposium today. So I say this every year, but we really do have a stellar lineup of speakers to tell you about the latest research in prostate cancer, as well as provide some more practical information that hopefully will be useful for you day to day. And the whole point of this symposium is to be very interactive. As you'll see from the schedule, we have time set aside for questions and answers, and I'll get into that in a little bit more detail in a moment. So we conceived this event 5 years ago really as a way to kind of give back, if you will, to the community, to provide information and education for those of you having to deal with a diagnosis or a loved one with a diagnosis of prostate cancer. And we've carried this on each year. So the Institute for Prostate Cancer Research is a collaborative effort between two world-class research organizations, the University of Washington and the Fred Hutchinson Cancer Research Center. So we agreed many years ago to jointly focus on our research and treatment efforts to cure this cancer. And then the clinical arm is called the Cancer Care Alliance, which is just across this parking lot here, and probably many of you are familiar with that. We do have a website for those of you that want a little bit more detail in terms of what the IPCR is all about, what its research mission is, and drill down into some of the projects. And we also give tours of the laboratories here at Fred Hutch and also at the university. So for any of you ever interested, we're happy to bring you in, show you the researchers, get to meet the young people who actually make the engine work. So many years ago, growing up as a small boy in Kansas, I used to read my grandmother's Reader's Digest. There are a lot of funny cartoons and things in it. And I remember back then there were these vignettes of I am Joe's X. I am Joe's heart, I am Joe's brain, I am Joe's lungs, etc. And I didn't pay attention to this one when I was a 10-year-old boy, I am Joe's prostate. I didn't think it was really that interesting at the time. I was more captivated by Joe's brain and Joe's lungs, but I think this little discussion really hits home now when you read it. So Joe knows, like most men, that I can be a real troublemaker, is how it starts out. But like most men, you prefer to ignore me, but you should know better. We're going to hear more about screening later today, which is relevant certainly for that statement. I'm one of the hot spots in Joe's body, a design nightmare for which nature should be hanging her head. Red-brown, about the size of an English walnut, I produce a variety of grief. I can disturb Joe's sleep by requiring several trips to the bathroom each night, or kill him with uremic poisoning due to urinary blockage. And if Joe lives long enough, I'll become a cancer site far surpassing the lungs in importance. And that's really why all of you are here today. So the intent and objective over the next morning and early afternoon session is really to provide information back to you concerning the current state of prevention, screening, and treatment for prostate cancer. We hope to highlight exciting new developments, be a bit forward-thinking of things you may anticipate over the next several years. And in this case, we have a special part of the symposium devoted to immunotherapy, where you'll hear really exciting work in leukemias and lymphomas, and we hope that's going to move into the prostate cancer field soon. We also want to provide this forum for addressing questions that you may have, and so NOLA is passing out index cards or cue cards for you to write questions on. We'll have the Q&A session and we'll pass the microphone around, but if you're shy or you want to get that question in early, you can give the cue card back to NOLA, and I'll be moderator to provide that to the people answering the questions. And then finally, we want to emphasize that this really is a partnership. It's a partnership between the researchers, the clinicians, and all of you, both for getting the information out, participating on clinical trials, and advocacy for research funding. That's really the only way we're going to make continued progress here. Here's the program. You've got it, hopefully. That was handed out. These talks try to change a bit every year for those of you who have been in past research symposiums. So they have slightly different orientations. You can see we're going to talk about screening. We have one of the world experts here in understanding the nuances of PSA screening, pros and cons, all the way through the rest that you'll see here. One omission, which has been a very popular one in years past, is talking about diet and nutrition. So Marion Newhouser couldn't be here today, but I can tell you what she would say. She would say a heart-healthy diet is a prostate-healthy diet. She would say eat your cruciferous vegetables and legumes, so beans, lentils, that sort of thing. So she can provide more details on that. But we didn't serve that for breakfast this year. Didn't want to keep you all away, but next year that might be on the menu. Then we have this period for question and answer, so we're not going to have questions in between each talk, but hold them, and then we'll have a 15-minute break before, or 15-minute interval before the coffee break to answer those questions. Then we have the session on immunotherapy, time for Q&A then we'll provide lunch for you, and then the afternoon we move more into advanced prostate cancer, metastatic prostate cancer, and we have a series of talks around that area, and then another time for question and answer, and then we'll adjourn. I want to dedicate this symposium, we've started to do this the last few years, to two individuals, Pete Derrick, who is a prominent Seattle native, a businessman in the community, a supporter of the IPCR, University of Washington, and Fred Hutch, and then Norm Breslow, who was an epidemiologist here at Fred Hutchinson and biostatistics at the University of Washington. Truly a world leader in cancer epidemiology that really set the stage for how we understand disease incidence, and it's very sad to have lost both of these men this year. And then I also want to dedicate this to all of the support groups, us to the groups that in your communities and around the state and around the country that communicate and provide a venue for men to come and talk about their issues related to prostate cancer. So I also want to thank Nola Klemfus, who's really the organizer here of this symposium. She's in the back of the room there. And if you have any questions throughout the day or even afterward, you can email her or talk with her. And also the development staff here at Fred Hutch and the University of Washington. I'll give you their emails at the very end if you want to contact them. The support groups again, and then we have two corporate sponsors, Bayer Healthcare, that develops, has a radium-223 drug used for treating advanced bone metastases, and Genomic Health, which is a molecular diagnostics company, so they've provided support for us, and then the generous donors to the Institute for Prostate Cancer Research. A few final details, and then we're spot on time. So at lunch, we'll have some tables there from support groups, and also to discuss a very important initiative that we've called Prostate, or Empower Northwest, which is a data repository to understand how men choose therapies and understand what side effects occur. And Nola's going to talk about that in the afternoon in more detail, but there'll be a table at lunch to talk about that. All of these talks will eventually end up on YouTube, so if you don't catch something as people are speaking today, it'll be up there in the future for you to revisit it as often as you like. We'll have the questions, as I mentioned. The index cards should have been passed out, but if you need more, raise your hand and Nola can give them to you. And then feedback is critical. As I'll reiterate at the end of the day, we want to continue to make this symposium better. So if there's any topics you really want to hear about, and we heard last year a lot of questions about immunotherapy, which is why we had that component of the program this year. But if there are other key areas that you want to hear about in the future, if you want us to do this more often, right now we do it once a year, but any feedback is greatly appreciated. Okay, so we're spot on time. I'm going to just launch into session one. And our first speaker is Dr. Ruth Etzioni, who's a member here at the Fred Hutchinson Cancer Research Center in the Division of Public Health Sciences. And Ruth truly is an international leader in understanding screening for cancer. And in particular, she'll be talking about screening for prostate cancer. Many of you have probably seen all of the issues related to prostate cancer screening and the recommendations now against screening that is more or less official policy, and it's caused many family practice doctors and internists to not even discuss screening with patients. And Ruth has a very important and interesting understanding of that. So, Ruth?
Thank you, Pete, and good morning, everybody. It's very difficult to talk about screening in 15 minutes, and I'm very cognizant of time because I'm the first speaker, so if I end up being late, everyone else will be. So I very much welcome your questions, both on what the topics that I discuss and any other topics related to screening in the question and answer and later. I also want to just say a word about Norm Breslow. Norm Breslow was, in fact, my first mentor here. I came to the University of Washington as a freshly minted PhD to a postdoc, one-year postdoc in the biostatistics department, and Norm really was a giant and quite intimidating in person, and I was fortunate in that he actually wasn't here that year. So we communicated solely by email, and in fact, I worked on a project that was really a love of his, and that that led to tremendous advances, and it was a project in a pediatric kidney tumor called Wilms tumor, and that group that he formed that gathered data and did so much work on that tumor really led to paradigm shifts and advances in treatment of that. So very, very sad to lose him. My title is Prostate Cancer Screening and Treatment in 2016. Of course, this is actually at this point a decades-long story. I'm going to try to focus on where we're at and some ideas about where I think we might be going. And as you know, prostate cancer screening has had its ups and downs, kind of like this graph that shows death rates from prostate cancer beginning in 1975 when national level data from the Cancer Registry first became released, and the most recently numbers have been released for 2013. So I am talking about 2016, but all the registry data that we have is 3 years behind. So the most recent year is 2013. And what I've shown on the graph are two key points in time: in 1986, when there was FDA approval for the PSA test, and in 2012, when the U.S. Preventive Services Task Force most recent guideline on prostate cancer screening was finally published after several years of debate following the release of their draft guideline. So 2012, U.S. Preventive Services Task Force issued a D recommendation: do not screen for prostate cancer. This recommendation is designed to apply to average risk men, but as I'll mention later, I think it is being applied more broadly and is in fact being misunderstood, particularly with respect to African American men. So why did the U.S. Preventive Services Task Force issue the D recommendation? If it was a couple of years ago, I would have spent the entire talk talking about this, because we spent a lot of time as the recommendation was being debated, weighing in on our perception of why we felt the evidence had been misinterpreted in producing the guidelines. So the evidence did not come from the population curve that I just showed you, even though that population curve looks very compelling in terms of the timing. We have to remember that the population is the ultimate uncontrolled experiment, and often there's more than one thing going on: changes in treatment, changes in screening, changes in behaviors, et cetera. And population curves are very difficult to interpret. Rather, the U.S. Preventive Services Task Force based their recommendations on two controlled studies: the two large trials of prostate cancer screening, the PLCO trial in the U.S. and the ERSPC trial in Europe. And I've shown you the mortality results, the cumulative mortality curves from those trials. And you can see that in the US trial, there really was no difference, and even a slightly higher mortality in the screen relative to the control, completely not statistically significant. And in the European trial, there was a difference with the lower mortality in the screen group. And the interpretation of these results was first that, from the task force, was that really the benefit of screening was equivocal, because there was no benefit on one trial and a modest benefit on the other trial. We now know, and even the trial investigators in the US will acknowledge, that the US trial is essentially a failed comparison of screening versus no screening, because there was a lot of screening on both arms of the trial. And the European trial was a modest absolute benefit, but over a limited time. And in fact, we have shown an inflated estimate of overdiagnosis due to screening. But the result of that was a perception that the harms of screening really outweigh the benefits. So this then came together into the reasons for the D recommendation. And I'll just say a word about our work. If you imagine an orange, right? And you have an orange, you can see the outside of the orange. We know that inside the orange is a lot of juice, right? So our work is analogous to squeezing the orange, because we have empirical data, we have a lot of data, but the question is, what's the story underneath that? What is really going on with disease progression, and can we try to understand that from what we see? So if you look on the right-hand side of this slide, what I've shown you is prostate cancer incidence in the US population. You can see it's quite dramatic, right? There's a big spike. That's right when screening came in very rapidly into the population in the late 1980s and early 1990s. Now, somebody looking at this incidence curve might say, okay, that's an interesting incidence curve, but when we look at the incidence curve, we see a lot of information there. That incidence curve gives us information about disease natural history, progression in the absence of screening, and overdiagnosis. And so the models that we develop and the methods are designed to extract that information from the data that you observe. And in fact, our analysis, not having a lot of time, I'll just mention our analysis of this curve and our models are what helped us to get a more accurate assessment of overdiagnosis that was half or less of what was projected by the European trial. So, given the D recommendation and looking at the news of the year, there was a lot of news around the time that the 2012 incidence data came out from the registry. And I'll show you that in a moment, questioning whether men were stopping screening, if screening rates were going down in response to all the press that had been going on for a couple of years around the D recommendation. And what this shows is self-reported PSA screening by age and by year. So blue is 2005 from the National Health Interview Survey, yellow is 2010, and gray is 2013. So you can see that there's a drop there from 2010 to 2013, pretty much across all ages. And in fact, if you look at the last few years of incidence, you can see that prostate cancer incidence is really going down faster, and there was a particularly big drop between 2011 and 2012, and the last point here is 2013. So a lot of concern about stopping prostate cancer screening in the population. So one of the things that we did at the time that the draft recommendation came out was we said, what would happen if men stopped screening, and how long would it take, and what would incidence and mortality rates go to? And because we have some understanding of disease progression in the population, we can project out what would happen under different patterns of screening. So the first thing I'm going to show you is incidence of advanced cancer, a diagnosis. And so this wavy line here is advanced cancer, incidence of advanced cancer at diagnosis, and you can see this precipitous drop right around 1991 and 92 when screening was being adopted rapidly. And we've projected out that the majority of this drop is due to screening. We can't quite replicate it. That might be our modeling. It may be other factors, awareness, imaging. It's unclear, but certainly the majority of that drop is due to screening. So now what would happen if we stop screening? Well, we'd see those metastatic cancer rates beginning to go up if screening is discontinued. And we would see deaths going up, not to the original level of deaths as the way the metastatic cases would go up, because there are indeed other factors at work in that decline. And a lot of our work has been trying to decompose that decline in mortality into reasons, including screening. There certainly have been changes in treatment. There certainly has been an effect of screening. And even with changes in treatment and screening, we're not quite able to capture the drop in mortality. So we project that deaths would definitely go up if we stopped screening, but not to the level that they were originally at. We calculate that over the 13-year period from 2013 to 2025, we would see 36,000 more deaths due to prostate cancer if screening were to cease. So we have always said, we've never agreed that screening should be stopped. We've always said that there must be ways that we can use screening in a better manner to try to preserve the benefits of screening, but maybe to reduce the harms of overdiagnosis and of excessive intervention, which definitely we need to be concerned about. And so when we think about doing that, about screening smarter, preserving the benefit while reducing the harm, we have to understand the nature of screening as an endeavor. And the fact is that screening as an endeavor, and in fact for all cancers, kind of follows this pattern, that among younger individuals, you have to do many tests to find cases of cancer because it's much rarer. And in older individuals, and particularly in prostate cancer, there are many cancers, but many of them would not present clinically if left undetected, and therefore are overdiagnosed and potentially overtreated by screening. I have two test cases here. One is Scott Kelly. He and the astronaut, I was actually on a panel with him once at an AUA meeting, and he and his twin brother both got prostate cancer in their 40s, and of course Warren Buffett, who got prostate cancer at age 81. So what does it mean to screen smarter, taking into account that screening as an endeavor has these properties? The first is to really think about being conservative with screening. And what does that mean? Maybe not to screen the youngest men, perhaps to get a baseline PSA, which I'll talk about in a moment, make it harder to diagnose older men, maybe by having a more conservative threshold for prostate biopsy, and screening less often. We can preserve much of the benefit not by screening every year, but a little less often. If we can't be conservative with screening, we should be conservative with treatment, by which I mean low-risk men, and people will say we don't know who's low risk and high risk. We have a good idea who is low risk, and low-risk men, and it's now becoming accepted that active surveillance is a very, very reasonable option for low-risk men. So how do we know that this is a smart way to screen? Because we did a recent analysis of a lot of different strategies for screening, beginning at different ages, screening for different numbers of years, screening at different intervals, using different thresholds for biopsy. And what I've got here is I've got two complicated-looking graphs that I'll try to explain in a minute. Each graph shows the benefit. Here's the benefit in terms of gain and quality-adjusted life expectancy. So we're not looking only at the increase in life years, but we're adjusting it for quality of life, which can be reduced by side effects of treatment, for example. And over here we have the costs. And the costs basically combine all the screens that we're doing, all the false positives, all the treatments that we're doing. And over here to the left of the dashed line are all the strategies that are negative in terms of quality-adjusted life expectancy. They don't improve it. And what we see is that when we're using, when we treat according to contemporary frequencies and treating low-risk cases, we have a range of costs and we have a minority of strategies that are positive. And the ones that are we want to look at the strategies that are down here because they give us the most gain in quality of life and the lowest cost. And so the strategies that win over here are these ones. They have a high PSA threshold, and they have fewer screening exams, long interscreening intervals. However, if we refer low-risk cases to conservative treatment, to active surveillance, we bring costs down a lot across the board, and we have many more strategies that have positive impact on quality-adjusted life expectancy. So it really can help if we combine conservative treatment with conservative screening and conservative treatment. And so what we're looking to think even beyond this, to even what I'll say, maybe even smarter screening. So I have a question mark here, thinking about tailoring screening to disease risk. And who is high risk? Well, we know that African American men are high risk, men with a family history, more recently, clearly BRCA2 carriers, more generally high genetic risk, and Janet will address this. And it turns out that men with high PSA in their 40s are also at higher risk. And this is a graph that's based on a study of a Swedish data set where men had blood stored in their 40s, and then over the next 25 years, there was no screening in the population, but there's a registry which tracks cases and deaths. And those men in the highest quarter had much higher risk over the next 25 years of having metastatic prostate cancer. So perhaps in men in their 40s, that this can be used as a baseline to even determine whether they need screening and how frequently to screen. So finally, I just want to talk about variation in risk. I've got two slides, one about race and one about BRCA, but in the interest of time, I'll just show you the one about race. Well, this is very pertinent to me because I have people coming up to me at conferences and saying, we're losing funding for educating black men about prostate cancer screening because we're being told that we shouldn't screen. And black men have always had higher risk of prostate cancer diagnosis and death. And our models show that that's because really they get prostate cancer earlier and more frequently. And if we understand that underlying difference in risk, that it really pertains to the frequency of getting prostate cancer, then if men get prostate cancer earlier and more frequently, and we can estimate how much earlier and how much more frequently, which we have done with our models, we can think about how differently we should screen this higher risk stratum. And so what I'm showing here is the cumulative risk of onset of potentially fatal prostate cancer that would be cause death if not diagnosed and treated. And it's a little bit light, but this is for the average risk population, and this is for African American men. And so you can see that this one reaches the dark curve reaches the same level as the light curve earlier, all right? So the light curve at age 55 for all races is the same risk as in black men at age 45. And the light curve at age 50 is the same as in black men at age 42. So if we have a policy of starting screening at age 50 in the average risk population, then we should be screening black men starting at age 42. And if we have a policy of starting at age 55 in the average risk population at age 45, and we've mapped this out as well for BRCA, if BRCA, like in African American men, has a higher risk of onset, but BRCA men may also have a higher risk of progression, and then we need to think not only about screening earlier, but also about screening more often. So in conclusion, I think, again, if I was talking a few years ago, we'd be talking about, does PSA screening work, and what do the data show? In our opinion, it's not about whether to screen now, it's about how to screen smarter. And I haven't had time to talk about bringing in new markers for screening that we're also an area that we're working on. The benefits and harms of screening depend on how you screen and also on how you treat. And I want to just end by talking about back to the U.S. Preventive Services Task Force. They are reevaluating their guideline for prostate cancer screening, and I was very gratified that maybe they had heard what we said a few years ago, because a few weeks ago I got a phone call from them. Can we help them with their review of evidence about modeling? So here's holding thumbs. Thank you.
Thanks, Ruth. I know you're going to have a lot of questions about screening. Write them down, and in the QA session, we'll be able to ask them. So we're going to move now on into some treatment discussions. So our first speaker is Jing Zhang from the University of Washington, and